Hello, I'm Atul Devdar. On behalf of CME Outfitters, I would like to welcome you and thank you for joining us for today's educational activity entitled Hitting the Target with IL-23 Inhibitors in Psoriatic Arthritis. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider for continuing education for clinicians worldwide. Today's CME CE activity is also eligible for ABIM maintenance of certification points. So make sure you engage in today's event, answer polling questions, submit questions, and provide your feedback. Once you complete today's program, be sure to provide your ABIM ID and birth date in the evaluation. CME Outfitters will submit your maintenance of certification points. You can also claim this activity as CME for MIPS improvement activity. So please make sure to participate and provide examples of how you will change your practice, and CMEO will send your confirmation of your participation, which you can submit to CME, to CMS, sorry. As I mentioned, my name is Atul Devdar. I'm a professor of medicine and medical director of rheumatology clinics at the Division of Arthritis and Rheumatic Diseases in Oregon Health and Science University in Portland, Oregon. And let me introduce our faculty joining me today. Let me first welcome my colleague, Philippe Mies. Philippe is the Director of Rheumatology Clinical Research at the Swedish Medical Center, Providence St. Joseph Health, and also clinical professor at the University of Washington School of Medicine in Seattle, Washington. Welcome, Philippe, and thank
Hello,
you for
and
joining us.
thank you, Atul.
I would also like to introduce my colleague, Christopher Richlin. Chris is professor of medicine, University of Rochester School of Medicine and Dentistry. He's also chief of the Division of Allergy, Immunology, and Rheumatology at the University of Rochester Medical Center in Rochester, New York. Welcome, Chris, and thank you for joining us.
Atul, it's a pleasure to be here tonight with you and Philip and talk about this fascinating subject.
Thank you. So let me now review our learning objectives. Our first learning objective is to decrease diagnostic delays through better identification of signs and symptoms of psoriatic arthritis. Our second learning objective is to apply key clinical efficacy and safety data for IL-23 inhibitors to treatment decisions in patients with psoriatic arthritis. And our final learning objective is to collaborate with patients to optimize treatment regimens across the healthcare continuum. So let's dive in. And so I'm going to ask Chris first. Chris, can you discuss the link between the inflammation in the psoriatic skin, the bone marrow, and gut with enthesitis, synovitis, and altered bone phenotypes that we see in the phenotype of the psoriatic arthritis patient, and the importance of the IL-23, IL-17, and TNF pathways in the pathogenesis of psoriatic arthritis?
Surely, Atul. It's well known that psoriatic arthritis is characterized by great heterogeneity and complexity, both at the patient level and at the tissue, cellular, molecular, and cytokine level. And here we're focusing in on the tissues and cytokines and cells. So certainly the skin is a really central area of involvement in psoriasis and psoriatic arthritis, driven by interferon alpha and the IL-23/17 pathway, as well as TNF, resulting in the proliferation of cells in the skin, particularly the keratinocytes. But we also know that there are abnormalities or dysregulation, if you will, going on in the bone marrow and in the gut. In the bone marrow, we know from animal models and human data that there's myeloid changes, increased osteoclast precursors, and in the gut, there have been important links shown by Jose Scher and others between dysbiosis and inflammation and even IL-23. So these tissues, evidence suggests that their cells and cytokines can converge on musculoskeletal structures, such as above shown the enthesis in which you have the added factor of biomechanical stress and trauma, which can result in the release of a variety of cytokines. And evidence is now suggesting that IL-23 is probably one of those key cytokines. And similarly, events can occur in the joint that include the release of IL-23 and 17, and that whole pathway becoming activated with Th17 cells and type 17 cells that are CD8 expressing IL-17. And you have downstream of that events that lead to both new bone formation through the release of Wnt signaling pathways, as well as bone morphogenetic protein. And of course, the pathway we know so well, which is the generation of the osteoclast, which results in bone resorption. So what we don't know is that if in individual tissues, if there's a different involvement of these pathways, but at this meeting, there's actually an abstract from Pitzkalis' group that shows that in the skin, the transcriptomic in psoriatic arthritis is primarily IL-17, 23 driven, whereas in the joint is primarily TNF. So it may be that at different sites, we're having different contributions from these various inflammatory pathways leading to different events that may require us to think differently about therapy for certain manifestations.
Yeah, I think it's a great point that you make about the heterogeneity of this disease, and the clinical domains of psoriatic arthritis are quite variable. So, Chris, can you comment on how careful examination of each of these clinical domains about the heterogeneity of this disease, how can that help us for correct diagnosis of psoriatic arthritis?
Yeah, it's a really important point, Atul. And Philip Meese and Alexis Ogdi have shown us that when you look at patients with psoriatic arthritis, that they tend to have more than one domain of involvement, most commonly 2, 3, and 4 domains. So in order to be able to understand the extent and depth of that involvement, you have to do a careful initial evaluation. And as rheumatologists, we're really thrust into evaluating the skin and the nails as well, because often our patients come in with that being an important element of their disease from their perspective. So evaluating the extent and type of psoriasis, as well as involvement of nails with pitting and onycholysis. Obviously, peripheral arthritis is something we're very used to evaluating, but it's much more, many more joints are involved in psoriatic arthritis and RA, as we all know, including the distal joints and the axial skeleton, which I'll address in a moment. Enthesitis is another area that's a key element, hallmark feature of psoriatic arthritis. It requires full evaluation, dactylitis, and then lastly, axial disease. And this is really important to comment on because this is a prevalent domain of involvement in psoriatic arthritis, and often not fully evaluated by practitioners, and really involves carrying out the range of motion exercises, asking about inflammatory back pain, and oftentimes imaging, because it's important to remember that up to a quarter of patients that have axial involvement will be asymptomatic, but this will definitely influence the selection of therapy. So one has to evaluate the patient very carefully on initial comprehensive meeting them to understand the extent and depth of their involvement so you can craft a very good therapy regimen.
That's perfect. I mean, that actually is a great segue to get our audience involved here. So this is the first audience response. This is a question, and all the people who are participating should be able to see an audience response question on your screen. And you can vote anytime starting now. And the question is, how common is axial involvement in psoriatic arthritis? And your answer options are 0%, 5%, 50%, 70%, and I don't know. So please go ahead and vote now. So this is interesting, Philip and Chris. This is our audience has chosen 50% as the middle point here. 15% thought that it's about, what is this, 5%, and 5% think it's about 70%. So do you want to sort of address this, what you think is the correct thing? Maybe I should ask this to Philip.
Thanks, Atul. I think fascinating to see the array of responses. And of course, it's going to depend a bit on the experience of each of the viewers that are listening. But there have been some very good reviews from registries that have been emerging in recent years especially from Daphne Gladman's registry in Toronto, some from our registry, Corona in the United States, and also from Deepak Jadon in the UK. What we're learning is that although axial PSA is part of the spectrum of spondyloarthritis, and so you might think that it's very closely aligned with or similar to AX PSA. In truth, there are some very important differences. For one thing, there's a key genetic difference. Although many patients will have HLA-B27, not all. And so in most of these cohorts, we're learning that about 30% are positive for HLA-B27 as opposed to 85 to 90% in the axial SPA group. Also, we're learning that there are other genetic phenotypes such as HLA-B8. And interestingly, that's associated with asymmetry of radiologic findings. So you'll see a patient with, say, one sacroiliac joint that's very involved and the other one is completely normal in axial PSA, who happens to be HLA-B8 positive. There are also other key differences, including the fact that axial PSA patients may be either completely asymptomatic, even though they have the characteristic imaging findings, or they may have diminished symptoms. We find that there are more females that have axial PSA than axial SPA. They tend to have more peripheral disease, more peripheral arthritis and enthesitis. We may see patients that have cervical involvement or lumbar spine involvement, but no sacroiliac involvement. And then when we look at the imaging, we'll often see, for example, asymmetry of the syndesmophytes, these sort of chunky, so-called extramarginal syndesmophytes. So clearly, there's some important differences. And this may translate into differences in immunobiology and may translate ultimately into differences in treatment responses to different mechanisms of action.
Yeah.
And we're starting to learn that in some of our recent data.
Yeah. So I want to go back to the question that we asked to the audience, because 30% of the people said that they didn't know. And so this is an interesting thing. I mean, this was a trick question. Because the prevalence of axial disease, as Philip said, in patients with psoriatic arthritis varies, and that depends on the disease duration. And it can be between 25% to 70% patients with long-standing psoriatic arthritis. And also, if you take very early stage of the disease, it can be 5% to 28%. I mean, it depends on what is the stage of the psoriatic arthritis and how long the person has had the psoriatic arthritis. So you could have been right if you said 5%, 50%, or 70%. Any of that are correct answers depending upon the length the patient has psoriatic arthritis. Is that fair to say, Philip?
It is. And you brought out a very important point, that since it tends to become more frequent as the disease matures in a person and they're into their 40s, 50s, it becomes harder to distinguish from osteoarthritis on imaging, because you're going to see mixtures of osteoarthritis as well as PSA manifestations.
Yeah.
Philip, I have a question for you. You presented a poster at the ACR, the last ACR meeting, where you looked at back pain in psoriatic arthritis patients in the Corona registry, and you found that it was very prevalent, but that a smaller percentage actually had axial disease that was thought to be related to axial involvement.
Yes.
Were you able to determine what was a positive predictive value of inflammatory back pain in that population for real axial inflammatory involvement?
So no, we weren't able to give you a precise number, but you're pointing out an important thing, that many patients have back pain, period. And so in our study, roughly twice as many had symptomatic back pain than the investigators thought had axial PSA. And then the question arises, well, what about the possibility that there is actually axial PSA hidden amongst all those people that we thought had degenerative arthritis? And so sometimes we have to just simply see what happens with treatment before we can really know.
Yeah. Great discussion. Philip, can I ask you about changing it slightly about the comorbidities in patients with psoriatic arthritis. What's your approach when you're screening for comorbidities in your psoriatic arthritis patients?
Well, to start with, I put on an internist hat when I'm getting to that point in the discussion with the patient, and I start to ask questions like, do you have any problem with hypercholesterolemia? Or do you have hypertension when I'm looking at their medication list? Or do you have elevated liver function tests and you happen to be obese? So we're beginning to realize that there are some important genetically determined comorbidities, cardiovascular disease, fatty liver in patients with obesity, but also important problems with depression, anxiety, the potential for suicidality, as well as associated conditions such as uveitis and inflammatory bowel disease. So you really do have to broaden your thinking and either ask the patient to help you with addressing these directly yourself, or better, bring in the village that's helping to take care of the patient and making sure that you're communicating either with your notes or through the patient for managing some of these important comorbidities.
Yeah, the anxiety and depression is also a major issue in these patients. You want to address that as well? I mean, that's something that we generally may or may not ask in our busy rheumatology clinic.
We tend to shy away from that because we don't want to open up the Pandora's box of getting into the patient's emotional life, but it's important. Many studies have shown that psoriatic arthritis and psoriasis combined are some of the most prominent diseases to have associated depression and anxiety, and these really do need to be addressed as part of the overall comprehensive care package of the patient.
I would say too that this is really, I'm sure both of you feel the same way, has really come to the forefront with the pandemic, where anxiety levels are at so high we haven't seen before, and it's something we try and address in our clinic with them, and it's very challenging.
Yeah, and one more thing I want to add is, and we'll discuss this later about the disease activity, and several times we depend on the patient's symptoms, and we need to basically be asking this question: how stressed are you in today's world? Because that produces all kinds of problems of sleep disturbance and aches and pains and other things. So, Chris, let me change gears to classification of psoriatic arthritis. Are there any good tools for classifying psoriatic arthritis?
Yes, Atul, there are. So the tools that we use are shown on this slide. These are the Casper criteria. Again, I want to emphasize that psoriatic arthritis in the clinic is a diagnosis from clinical judgment, and we don't necessarily or usually don't apply classification criteria for diagnosing our patients that we see in the office. Although these classification criteria, on the other hand, are very helpful. So the idea here is a patient at the stem needs to have inflammatory musculoskeletal disease, defined as either arthritis, spondylitis, or enthesitis. And then they also need to have 3 or more points from the following areas. So evidence of psoriasis, either current personal history or family history, and you can see the point allocation there. Psoriatic nail dystrophy, which usually presents as onycholysis or pitting or red spots. Negative rheumatoid factor, dactylitis, current or recorded by a rheumatologist, and then radiographic evidence of juxtaarticular new bone formation. And so you would reach a diagnosis here if you obviously have 3 or more points. I must emphasize that one of the challenges we've run into in working with our dermatologic colleagues when we talk about these criteria is defining inflammatory musculoskeletal disease. And GRAPPA actually has taken steps to work with dermatology so that they understand the meaning of that in the clinical setting and in the clinical trial setting. But that can sometimes bring up some questions.
So interestingly, our audience is very already involved and they're asking questions. Several questions are coming in. Do you know about the prevalence of psoriatic arthritis in Blacks and Hispanics? I mean, is it different than that in white Caucasian people? Either of you?
You want psoriatic arthritis or psoriasis? Was that?
Why don't, I mean, the question is on psoriatic arthritis, but why don't you tell us about
Well, yeah.
psoriatic
So the
arthritis and psoriasis?
yeah. So I'll comment on the African American. Philip can comment on Hispanic. So in the African American population, it's less prevalent. It's very interesting, and and I've never really understood this until I went to an international conference. And at the international conference, there was the prevalence of psoriasis was quite high in Central and East and South Africa, whereas much lower on the West African coast. And I think one of the reasons that the prevalence is lower in African Americans is that they were brought here from the west coast of Africa, where the CW6 gene, which is associated with psoriasis, as you know,
Mm,
appears to be much less prevalent. So
mm.
it is certainly a lower prevalence in African Americans, probably for that reason. Philip, you want to
So,
comment on Hispanic?
sorry. So, was it for psoriasis or both
Well,
psoriasis and
so
psoriatic
so if your
arthritis?
prevalence of psoriasis is much lower, your
I
prevalence
see.
of psoriatic arthritis is
Is also
also, we
low.
know it's
Fair
about
enough.
30% of
Yeah,
patients with
yeah,
psoriasis.
yeah. Good point.
My awareness of the Hispanic population is that it's going to be fairly similar to the Caucasian population. And the one other thing I would add in is that if we go to Japan, for example, you also see, like the point that Chris was making about some black portions of the black population, much less in the way of psoriasis and psoriatic arthritis. So that's going to end up being ultimately a genetic reason for
Yeah,
all of that.
yeah, yeah. There is somebody pointed out, and it's an important point. The slide that we are looking at, Caspar criteria, there is no point for psoriatic nail dystrophy, and that should be one.
Yes, that's an
Yeah, so
omission.
it's yeah,
Thank
there's an omission. So
thank you.
yeah,
Sorry.
people are very engaged. Wonderful. All right. So, Chris, do you initiate a workup for psoriatic arthritis? And when you see the patient, what after you examine, you made the diagnosis, and you rightly said classification are not to be done in the clinic. That's for enrolling a patient into clinical trial. What's the workup? What do you do?
Well, obviously, the really important part of the workup is securing the diagnosis. And so we have to keep our differential wide, not only including lupus and rheumatoid arthritis, but also axial spondyloarthropathy, which sometimes can be very hard to differentiate, other spondyloarthropathies such as inflammatory bowel related arthritis, reactive arthritis, etc. So, in order
Mm,
to help make that differential diagnosis or secure it, we do a number of careful evaluation we've already talked about, and also the usual kinds of things we get in our patients in initial evaluation, CBC, chemistries, SED rate and
yeah.
CRP, and these other tests, which include ruling out rheumatoid arthritis, lupus, and of course HLA-B27, which is still one of the most prominent gene in the class 1 MHC that's associated with PSA. If there is the presence of an effusion, we will tap it because these patients can also have crystalline disease. And probably most different from RA is that the radiographs that we will obtain tend to be different. So not only do we include the hands and the feet, but usually I do an AP pelvis as a baseline. And if there's any suggestion of thoracic or neck pain, I will do a plain film of the thoracic spine and also of the cervical spine. So somewhat different, although a lot of overlap with the evaluation you're going to have for a patient with rheumatoid arthritis. And then most importantly, and not emphasized enough, is trying to basically understand the patient's view of what they have and how
Mm,
it's impacting their life, so that when you sit down and talk about the therapies, you're addressing the needs that they have, and then you can both plan together of what does it look like to have a good outcome here. I think that's really important
yeah,
to establish very early on.
yeah. And the other question that comes up, of course, at this time is then how do we decide about the severity of the disease? I mean, when you're doing this workup, some people have mild disease, moderate disease, or severe disease. So, can you tell us about what is severe psoriatic arthritis or severe psoriasis, say, compared to not so severe? Because this is again ultimately going to be important when we are going to discuss therapy and how extensive therapy we are going to use in these patients.
So, of course, this is severity in the eyes of the physician beholder. The patient can be very different. We've learned from many studies that that's often the case, and it's important to keep that in mind. But from our point of view, severe elements of PSA include erosive disease, of course, or joint space narrowing, cartilage damage. Elevated acute phase reactants tend to be associated with more severe disease and polyarthritis. Damage, either ankylosis or severe erosions, or obviously flail joints like you might see in patients who have arthritis mutilans, although this may not represent activity but chronic damage, and one needs to differentiate between
Yeah.
those two.
Yeah. I
Um,
think that's very important. Yeah. The
yeah,
activity
I know. Yeah,
and the
it
severity.
is,
Yeah.
and you've raised
Yeah.
that point. And I agree with you, Atul.
Yeah.
Obviously, the effect on quality of life and function, the number of involvements of sites, the domain involvement. Having 7 domain involvement is usually much worse than having 1 or 2. And then function and the progression of disease. And I won't
Yeah.
go in detail on the right, but obviously psoriasis is based on extent, the areas of involvement, genital areas, face, hands can be more severe, and then the effect on mental and physical functioning. So these all
Yeah.
have to be taken into account as you're
Yeah.
trying to put together a therapeutic plan for the patient.
Right, right. So there is a question, and we just kind of mentioned that. And the question is, does disease activity directly coordinate or correlate with severity? And I mean, I think what you're saying is, if there's a high disease activity, then of course that's a severe disease. But at the same time, there may not be disease activity. The patient may have arthritis mutilans, so very severe disease,
Mhm.
but they don't have any activity. It is burnt out. They have got destroyed joints. So that would be an example where the disease activity is not very high, but the disease severity is high because they have got totally destroyed joints. And so we need to always keep that in mind when we are deciding about the treatment that we are going to go next, whether this is disease activity or whether this is disease severity. So with that,
Atul,
yeah,
just one comment on that, and I totally
yeah,
agree. What
yeah,
I've learned over the years, and I know you two will agree with me, is that severity is totally in the eyes of the patient.
yeah,
And what I
yeah,
mean by
yeah.
that, there
Fair
are
enough.
patients
Yes.
whose arthritis can be completely subdued, and they
Yeah,
have one little minor psoriasis lesion, and they are
yeah,
totally miserable, or vice
yeah,
versa,
yeah,
right? So
yeah,
you're
yeah.
always adapting to the view of the patient in terms of how they think they're doing, and it
I agree.
varies from one person to another in a very dramatic fashion.
Right, right. No, thank you. Thanks for that. So let's shift to treatment, since we are now talking about, we have seen the patient, we have made the diagnosis, we have done the initial workup, we have decided the severity, etc. So when you consider treat to target, how do you define a quantifiable target for psoriatic arthritis?
Oh, that's a difficult question. There are many targets out there that have been established with a lot of work and a lot of validation. But the target that I particularly like, and I think Dr. Meese will agree with me, is shown here, and that is minimal disease activity. And the reason that we like this outcome measure is it is comprehensive. It takes into account those domains that really have an impact on patient, how they're feeling, how they're functioning, and
Mhm.
they include the joint counts, the skin score, the pain score, how the patient sees themselves doing globally,
Mm.
function, and then enthesial points. And to
Yeah,
achieve MDA, you need to achieve 5 of the 7 criteria. So it
right.
requires careful longitudinal evaluation after an initial comprehensive sort of alignment of where the patient is. But
Yeah,
I think
yeah.
this is very powerful.
So
I'm going
I
to just
always,
throw,
yeah,
if I could throw in
go
one
ahead,
thing.
Philip. Go ahead. Go ahead.
This is very doable in the clinic. So you is it tender and swollen joint
Yeah,
count? We all do that anyway. BSA
right.
less than or equal to 3%.
Yep, yep,
So this is 1% of body surface area. So that
yep.
takes 3 seconds
Yeah,
to estimate. We've got 3 patient-reported measures, and then however you do enthesial assessments, less than or equal to 1. It's so easy to accomplish, and it gives the patient a
yeah,
quantifiable target.
yeah. So let me push back a little bit on this. I mean, I like this, and I also use this hack. HAQ. This is now health assessment question, and this is function. And we were just before discussing about severity and activity. And of course, if somebody has got active disease, their function can be bad. But somebody who has got burnt out disease, the example I gave earlier was arthritis mutilans, their hack is going to be really bad. So do you think we really should have a function in disease activity measurement? Philip, I should ask you this.
So The answer is there are certain people that feel strongly, Joseph Smolin amongst them, that we shouldn't have a hack because he has observed that in rheumatoid arthritis assessments that you can have this phenomenon you just described, fixed hack in people that are quite disabled, which doesn't budge. And that
Exactly. Right.
prevents you from getting into a state of MDA.
Yeah.
So with that nuance or caveat, I would say that otherwise, for the great majority of patients that we see in the clinic, this isn't a limitation of the measure, and I still feel that it's a overall good measure for the majority of patients. It's just the patient that you've picked out, the bad mutilans, for example, or someone with a pretty ossified spine, where this may be a limitation.
Do you have this in your EMR by any chance? Is another question. And can the nurse practitioner do this? I mean, you do work with nurse practitioners.
Yes, the nurse practitioners, in fact, are the ones that do it all the time in our practice. And we record it in the EMR, as well as recording it on all the Corona CRFs, because we've enrolled all these patients in the Corona registry.
Yeah, I think it should be easy to get into Epic if people are using that. I'm going to ask Chris. Chris, can you tell us about the currently available therapies?
Sure. So this slide shows our very large tool chest that we have available to us in order to treat patients with psoriatic arthritis with really a great number of options. I'm sure Philip is smiling back there because he did the first biologic study in psoriatic arthritis, I believe in 2001, with etanercept. And now here we are 20 years later almost, and look at the wide array of options that we have for our patients. So moving, non-pharmacologic therapies, I can't emphasize enough how important those are, particularly weight loss and exercise. The various symptomatic treatments, which we'll see moving forward in one of the treatment recommendation slides, and then all of these different groups of agents, including oral small molecules, TNF inhibitors, agents that block IL-12, 23, and 17, CTLA-4 Ig with abatacept, JAK inhibitors, and now most recently, those agents that are targeting IL-23. So this is really quite incredible. But I would say that with one word of caution, and that is, while these have really increased our availability of agents and options for patients, our ability to move the goalposts in terms of remission are still fairly limited compared to what we're seeing with psoriasis. So we still have a major challenge in front of us to improve these outcomes. And I know that it's something we're all thinking about.
So there's a kind of a glass ceiling that we cannot break for the arthritis part or the musculoskeletal part, whereas dermatologists, I always think that they always get PASI 75, PASI 90, PASI 100, and we are stuck with ACR 20, 50. I mean, is there a pathological, physiological, basic reason for this, you think? Why are we stuck there?
I think it goes back to the first slide you asked me to comment on, and that is the complexity and heterogeneity, and that we don't really know at this point in time how to, in an individual patient, focus down on those pathways that are operative in that patient's disease with the proper biomarkers or precision-based diagnostic approaches that we're starting to see evolve. And I think that's when we're going to see a marked improvement in our ability to induce remission.
Yeah. So since we're talking about this ACR 20, which is what our basic measurement is for the efficacy, Philip, let me ask you about the efficacy data for these current therapies that Chris just now spoke about.
So here you see a bar graph that is doing what we are not really supposed to do, which is as if we were comparing one drug to another. These are all completely separate phase 3 trials, which establish the efficacy of most of the agents here in psoriatic arthritis. And as you can see, there's a range of efficacy that's shown here. Only recently have we seen the first head-to-head trials done in PSA. For example, there's a methotrexate versus etanercept study called the SEAM trial, We've got the ixekizumab versus adalimumab or SPIRIT head-to-head trial, and then most recently the secukinumab versus adalimumab or EXCEED trial. What it's showing us is that we have ability to achieve ACR20 response, but also in the, for example, when we use MDA criteria or very low disease activity criteria, which is really akin to remission, or one of the other measures that we're now using in trials like the DAPSA or the PASDAS, we can show that approximately 20% of established patients up to about 50% of very early patients can achieve targets of remission. And this is showing us that all of these various mechanisms of action can achieve those kinds of results. It's important because we know that there may be loss of effect with time if we use any of these. And so it's important to be able to have options to move between.
Yeah, a couple of questions have come up. One is, let me ask you about methotrexate, because methotrexate has got kind of, initially we thought it doesn't work, but then Philip, your study actually showed when that methotrexate versus etanercept, that study showed that methotrexate actually works. And the question is methotrexate approved by FDA or not? Is it, here it says it's not approved.
That's correct. So methotrexate isn't approved, although we've used it forever. And part of that had to do with the fact that there were very few studies with it. And up until this, the study that's on this particular graph is that by Gabriel Kingsley done in the UK. And although this shows you the ACR20 response, interestingly, in that study, it was not statistically superior to placebo. Mm-hmm. You can see it's numerically a little bit better, but not statistically. So at the end of that trial, it was concluded that it wasn't a disease-modifying drug. And it wasn't until we saw the SEAM trial, although not controlled with placebo, where we saw higher effects in not only the arthritis domain, but also enthesitis and dactylitis. Yeah. So etanercept bested methotrexate in that study, but methotrexate did very well.
Yeah, and again, it's symptom modifying, right? I mean, we still cannot call it disease modifying even from the SEAM study, right?
That's correct. Thank you for making the observation.
Chris, let's talk about some guidelines, because there are several treatment guidelines that are up there. And I know that you are, and Philip, and all three of us, in fact, are members of the GRAPPA. Can you summarize for us the GRAPPA guidelines and then the EULAR guidelines, for example, for psoriatic arthritis?
Of course. So the GRAPPA organization, as most people know, is a organization which has both dermatologists and rheumatologists, methodologists, patient partners, and it tends to have a more global perspective. In fact, we first met many years ago, and we were drawing up outcome measures for psoriatic arthritis. We forgot skin. And then the dermatologist reminded us very quickly that's an important domain in psoriatic arthritis. So with that in mind, you can see here that we have the domains laid out in front of you. And we think that's very important, as I said at the beginning, to ascertain which domains are involved in an individual patient, and to use those domains to help you craft a treatment regimen. And this particular slide, which shows the treatment recommendations from 2016, illustrate how one can do that. I should point out that these recommendations are being revised and should be out in the second quarter of 2021. So here you have this sort of global approach. And then the next slide, which is the EULAR recommendations, takes a whole different slant on this. So they divide this into different phases. So the phase where you come in and phase 1 not shown here, where you're using NSAIDs and intra-articular glucocorticoids. Phase 2 where you're moving to conventional synthetic DMARDs, and then phase 3 into the biologic DMARDs. In actuality, when the EULAR recommendations, the former version came out, there were quite a bit of differences between the recommendations from GRAPPA and this group. But with this more recent update, there's much more alignment in terms of how to approach patients with PSA. But I think Atul, you and Philip will agree with me that these guidelines can only go so far
Yeah.
because of the complexity and heterogeneity that individual patients present with and their own comorbidity profile. These guidelines can give us some ideas of what the literature tells us for certain questions and certain presentations, but a lot of the time it really combines knowledge of the clinical trial data and clinical judgment and really forming a close relationship to the patient as to what their needs are. And I think
Yeah.
that's what great clinical medicine is all about.
Yeah, I think here they're using the word phase. I think what they mean is line. I mean, so first line treatment, second line treatment,
Yeah.
third line, that's what we use. So
Yes.
I think the phase 2 is second line and phase 3 is third line and that kind of stuff. So
Or stage 1, 2, 3, 4, whatever. I agree with you.
yeah, yeah. So before now, since this is an American College of Rheumatology meeting and the American College of Rheumatology NPF guidelines were published, I want to get back to the audience to see their response and their knowledge about the 2018 ACR NPF, that is National Psoriasis Foundation, which, by the way, is here in Portland. So the 2018 ACR NPF guidelines recommend starting a TNF biologic over an OSM, that is oral synthetic molecule, in adult patients with active psoriatic arthritis and frequent serious infection who are treatment naive, or switching to an IL-23 inhibitor biologic over switching to an IL-17 inhibitor biologic in active psoriatic arthritis plus IBD despite oral small molecule, or switching to an IL-17 inhibitor biologic over a TNF monoclonal antibody in active psoriatic arthritis plus IBD despite oral small molecule. So you can vote anytime. And the fourth answer, of course, is I don't know. So please vote. Interesting. So people are saying that number 2, which in fact is the correct answer, switching to an IL-12/23 inhibitor biologic or switching to IL-17 biologic in active PSA plus IBD. 21% got this right. So, Philip, you want to comment about this?
I just think it's a comment about how
complex this is, right?
No, it's a comment about how frequently folks use the ACR guidelines.
I would have thought that this is kind of a complicated. I mean, people have to read and see what all does the patient have, and what all did they have before, despite oral small molecule, and now they have got IBD, and now what do I do? And it's a bit complicated.
So a key point is that one needs to take into account the contextual factor of IBD being present in questions 2 and 3. And so what is a reasonably safe medication to use in that context? It would be either the IL-12/23 inhibitor, or now in the more updated guidelines, that will include the JAK or IL-23 inhibitor, but not the IL-17 inhibitor.
Yeah, so that's why number 3 was wrong. And number 1 is wrong is because they've got frequent serious infections. So if they're frequent serious infections, then we will be, should I be using TNF inhibitor biologic? Probably not.
But it is confusing. It's confusing from the basic biology perspective as well. So what's really fascinating is that when you block interleukin 17, it can stimulate inflammation in the gut. And yet when you block IL-23, early evidence, we're still in early phase 2, suggests that it's very protective. In other words, blocking IL-23 lessens inflammation. And yet IL-23 and IL-17 are in the same pathway. So it's complicated, and it probably relates to the fact that there are cells that release IL-17 that are not IL-23 dependent. And also that it may be a timing issue, that early in the disease process, IL-23 is very important, and maybe not later. We know this with the axial disease, but it's really fascinating. And I'm hoping that in the next couple of years, Atul, that we'll understand this biology better, and it'll make sense, right? Because it's really fascinating.
I'm glad that you raised that point. I mean, so IL-23 there are cells which are IL-23 independent and they are still secreting IL-17. So fair
Yeah.
enough. So that's why IL-23 inhibitor will not sort of cause these kind of problems. But then why should IL-23 inhibitor help? I mean, so question number two, I mean, the correct answer, IL-12/23 inhibitor, I mean, ustekinumab is in fact is helpful, right? In
Yeah.
IBD.
Yeah.
So
Yeah. Yeah.
Correct. It's yes, it's approved for treatment of
Yeah.
IBD.
Yeah.
yeah. So
Absolutely.
I can understand IL-23 inhibitor not worsening like IL-17 inhibitor worsening, but now we are saying it is helpful, which is
Yeah.
also kind of complicated.
Yeah,
Yes.
so it turns out that in the GI tract, that IL-23 is probably a major driver of inflammation. One of the barriers to helping us understand that is we don't have good markers for the IL-23 receptor,
Right.
either
Right. Correct. Correct.
molecularly or
Yeah.
serologically, and this is proving to be a major problem in trying to understand this biology. But we'll get over that. It's just a matter of time.
All right. So now, since we already asked this question about the 2018 ACR NPF guidelines, Chris, why don't you tell us about what the recommendations are? What are the strong
Yeah.
recommendations? Yeah, go ahead.
Yeah, just to point out that this was a coming together, if you will, of the American College of Rheumatology and National Psoriasis Foundation. The NPF has been a leader in both psoriasis and psoriatic arthritis, and was a really great group of patients and methodologists and rheumatologists and derms putting together these recommendations. And so they used the grade system, and it was, I think it was a successful endeavor that was published in ACR. So in terms of here, it's agents with no efficacy in IBD should not be used in patients with IBD. Heat box warnings and smoking cessation. I'm not going to read all through these here, but clearly the point here is that they lay out, based on the evidence that's out there, what types of medicines you want to be thinking about in patients that have inflammatory bowel disease. And we know that anti-TNF agents, 1223 and IL-23 agents certainly don't make the disease worse in the gut. And there's evidence now, we already know from ustekinumab, and we're getting leanings with IL-23 antibody that they can actually be very beneficial in Crohn's disease, as can anti-TNF antibodies, except for etanercept. For some reason, etanercept is not effective in IBD. We don't understand the reason for that, but it's well known now to avoid the use of that particular anti-TNF in Crohn's disease.
Yeah. So these guidelines, and we all three of us participated in this. There are very, very few strong recommendations, and these are these strong recommendations. Most of the others are kind of not strong recommendations. They are conditional recommendations. And another that problem that happens with the guidelines is that by the time they come out, there is a new drug. I mean, we are actually already, you said, we have got, our toolbox has become bigger. So let me ask you, Chris, what are the clinical implications of these recommendations now that the first selective IL-23 inhibitor, guselkumab, has been approved, which of course was not there when these guidelines kind of came out? So has your approach changed, especially now that for patients who have lost efficacy or have side effects issues with the previous therapies noted here in these guidelines? I mean, these guidelines don't have pure IL-23 inhibitor.
Well, certainly, one could say that where you have IL-12/23, you could substitute 23 inhibition directly. Philip Meese talked about the head-to-head trials, which all the three of us applaud. I would love to see a head-to-head of ustekinumab against an IL-23 inhibitor in psoriatic arthritis. But I would say there certainly would stand a reason that that those two could be seen somewhat equivalently in terms of where you could use them. I think the other point to make here with these guidelines, because you mentioned this, Atul, that they can be outdated very quickly. When we put together these particular recommendations, there was not good data supporting the use of methotrexate in psoriatic arthritis, based on, Philip already cited the Kingsley study. And then the SEAM study came out and showed that, this isn't effective treatment. So we really had to come in and write an editorial when this came out saying, well, we have new data here saying that methotrexate is an effective drug. So it's always in motion, if you will. And once again, these are just meant to give you some framework. It's still an individual decision with you and the patient based on a lot of other variables.
I agree. And I mean, this is a live document in the way, and that's why ACR, every so often when the new data comes out, we always kind of get together, and then there is always a rehash of these guidelines, and we do that. So, since we're talking about IL-23, let's now focus on IL-23. And before we get into the data, again, I want to ask the audience another polling questions. And again, as before, you can vote anytime. So here is the question. Discover 1 and Discover 2 are phase 3 trials that evaluated guselkumab in psoriatic arthritis. Which of the following best describes the findings of these trials? And it's okay to say I don't know because we actually haven't shown you the data. But the answer options are A, guselkumab improved axial symptoms over 24 weeks. B, patients treated with guselkumab had an increase in IBD as a side effect. C, there was an increased trend in the major depressive disorder and suicidality in patients treated with guselkumab. And D, I don't know. And please vote. All right. So 44% said one is correct and 44% said they don't know. So actually this is A is the correct answer, and I'm going to actually show you the data about Discover 1, and I'm going to then invite Philip to speak about Discover 2. So let me start with the Discover 1 trial, which evaluated guselkumab in patients with active psoriatic arthritis who were biologic naive, or they actually had previously received TNF inhibitor treatment also. So 30% of the patients in this trial had received, they were experienced for TNF inhibitor. And this was a classic sort of double-blind placebo-controlled study. And guselkumab was tried in two different dosages, guselkumab 100 milligram every 8 weeks or 100 milligram every 4 weeks, subcutaneous. And what you see here are the ACR 20, 50, 70 responses. ACR 20 response was the primary endpoint shown here at week 24. And both these dosages every 4 weeks or every 8 weeks was statistically significantly different and better than the placebo. And as you can see, the ACR 20 responses is in the range of about 60% of patients having ACR 20 response, about 40% of the patients having ACR 50 response, and about 20% patients having ACR 70 response. I mean, those are the kind of numbers we generally like to see. The secondary endpoints for this study, there were three major secondary endpoints. One is Investigators Global Assessment of Skin, IGA. Now, we rheumatologists generally don't know much about this IGA. We know about the body surface area, and Philip said that the palm is 1%, and I also use that in my practice to ask the patient if this is 1% body surface area. So BSA we know, PASI we know, but investigator global assessment goes from 0 to 4, and zero means completely clear, and 1 is nearly completely clear. And so that was one of the major secondary endpoints. HAQ-DI, the Health Assessment Questionnaire Disability Index, was another major uh, secondary endpoint, and SF36 PCS or physical component score was the third. So this actually encompasses the patient's skin and their function and their quality of life in a way. And all these three major secondary endpoints, guselkumab, both dosages every 8 weeks or every 4 weeks, 100 milligram, were superior to placebo and quite significantly so at week 16 shown on the left side, and week 24 for the IGA, and week 24 data is shown for HAQ-DI as well as for SF36. So this was pretty successful study. This was the phase 3 study, Discover 1. So Philip, can I ask you about Discover 2 study? You were the first author on that study. Tell us about the Discover 2, the second pivotal phase 3 trial evaluating guselkumab in psoriatic arthritis.
This was a larger trial and done that way because there was a radiographic outcome as well. And the patients here were completely bio-naive.
Yeah.
Here we're looking at ACR 20 responses, and they were actually in the mid 60% range compared to placebo, which was 33%. And then you see the corresponding ACR 50 and 70. So quite good. And this is what we really like to see when we've got an efficacious drug. And the next slide shows the efficacy in the IGA measure that you spoke to earlier, the Investigator Global Assessment, very high degrees of response. And I should mention while here that in the pure psoriasis trials with this drug, there were head-to-head comparisons with both adalimumab in one study and secukinumab in another. And with this agent, it bested both of those mechanisms. We saw better responses, and with just every 8-week administration. So infrequent dosing, very high skin responses. And you see the physical function improvement here. And the next slide shows the important domains of enthesitis and dactylitis, which show resolution at week 24. And as we track out to 1 year data, which is we're not showing tonight, we saw even better responses over time.
Yeah.
And then the very interesting observation is here. So let me just give a little background on this one before I speak to the data. There had been a couple of important trials that showed that or suggested that interleukin-23 inhibition does not treat spine disease adequately. And one was a phase 2 study, relatively small study, with another P19 IL-23 inhibitor, which did not distinguish itself from placebo in treating ankylosing spondylitis, so radiographic axial SpA, in other words. And then there was
risankizumab, right?
Yeah. And then there was a trial with ustekinumab that you were the lead author on, Atul, which also showed failure, and that's a combination of an IL-23 inhibitor. And that one ended up being a surprise because there was an open label study that looked like it had good results, and thus they jumped right to a phase 3 program. So I can remember I was asked to write an editorial. Ian McGinnis and Stephen Siebert were asked to write an editorial. Why was it that IL-23s don't work in the spine? And we had ideas, as Chris alluded to before, that there might be differences in immunobiology between the entheses in bone and the spine and the peripheral entheses in joints, et cetera, or it might have to do with differences in the fact that the IL-17 is produced regardless of IL-23 stimulation of cells and so on. Then this study comes along. And what was done here was that the patients in both Discover 1 and 2 who showed evidence of abnormalities of sacroiliac X-rays and, in the case of Discover 1, or MRI scans that were historic, or in the case of Discover 2, taken at the time of baseline of the study. There were 30% of patients in both studies that had abnormal sacroiliac X-rays consistent with sacroiliitis. So these were patients that not only had elevated pain scores to get into this subset study, but also in the spine, but also had objective imaging changes. And so they were a more legitimate group to look at. And what do we see? We see important improvement in this is inactive disease, major improvement or clinically important improvement in a measure known as the ASDAS, which is a measure of spinal measurement that's validated in axial spondyloarthritis, and now here it's being used in axial PSA patients that the investigator deemed to be axial PSA. We also saw specific measures of spine pain that improved. So it raises the fascinating question that maybe there's enough difference in immunobiology between axial PSA and axial SpA that we might even see this mechanism of action helping and improving symptoms. So I think we're anticipating much more study along these lines as we go forward.
Yeah. So there is also some very recent data about guselkumab improvements in psoriatic arthritis. They persist through about a year. Can you comment about that? This is the Discover 2 study.
Yes. So this is data that shows us that out to 52 weeks, we have sustained effectiveness. These are ACR20 responses using a NRI analysis, which, as you know, is the most strict way of looking at data and treats anybody who even moves away as being non-responders. So this, I think, is very encouraging.
Yeah, this is remarkable. There was one thing which I forgot to mention in the Discover 1 study, since we are talking about efficacy. Discover 2 study, Philip, as you rightly said, everybody was anti-TNF naive. Discover 1, there were 30% of the patients who were TNF experienced, 10% patients had inadequate response. And we also looked at the ACR 20, 50, 70 responses in patients who were TNF inhibitor experienced versus TNF inhibitor naive. And interestingly, at least in the Discover 1 study, there was no, I mean, at least it looked very similar, the responses. Generally, what our experience is that patients who have experienced some biologic, their responses to the second biologic may not be as good as a patient who has been naive to any biologic. So that was also quite remarkable for the Discover 1 study. So, Philip, what is the data regarding the safety from these two pivotal trials? This is a completely new molecule, IL-23 inhibition.
It's reassuring. So we saw a very little signal for any serious infection. We saw no signal for IBD, no malignancy signal. There was no major adverse cardiovascular effects. There was no zoster, for example. And so and there was a slight elevation of liver enzymes in the guselkumab versus placebo group, no deaths. So in all, I think that the take-home message is that the safety profile is one where we don't have to lose sleep over it.
Yeah, there is a question, is this drug available now and how do you dose?
Yes, it is available, it's approved. And so the dosing is using 100 milligrams, so a single injection with either a pre-filled syringe or one of these injector devices. That's pretty cool. And it's given at baseline 4 weeks and then every 8 weeks thereafter. So pretty infrequent dosing.
Right. So there are a few other IL-23 P19 subunit specific inhibitors. Tridrakizumab is another one. So do you want to tell us a little bit about that study, tridrakizumab in active PSA?
So it's more or less mimics what we've just been through with the Discover trials, but basically showing, here we're showing several different dose arms. The key point is that they achieve statistical separation from placebo, although for whatever reason in this trial, there was a very high placebo response rate at the 24-week mark. But the effect size was still very good. So this drug, tildrakizumab, and then there's one more called risankizumab, are going forward into phase 3. So we'll have potentially, here we have the phase 2 risankizumab data. Interestingly, in this trial, there we had a variety of dose arms to try to show a dose effect. But in fact, even a single injection at the beginning of the trial had sustained responses over the time of observation. And so they have enduring effects, these drugs, and it looks like they're going to all be efficacious in PSA.
So just to confirm, so the tildrakizumab and risankizumab, both of these are phase 2 trials, right?
These are both phase 2 that we
phase
just
2 trials,
at,
right? Right. Okay. All right. Thank you for that. So let's switch gears and talk about how a patient-centered holistic approach can improve the treatment outcomes in psoriatic arthritis. And so I actually, and we actually mentioned this earlier about, Chris was mentioning this, that when we're discussing the severity of the disease, what is severe for us may not be severe for the patient, and what is severe for the patient may not be severe for us. This is a very interesting study called Disconnect. And this is the disconnect between the patient on one side and the rheumatologist and dermatologist perceptions of the symptoms. And what it shows, and I mean, this is a pretty complicated slide when somebody's looking at it, but look at the colors. And so the green bars, green horizontal bars, these are the patient's perceptions. And basically, these are all from joint pain and joint discomfort and swelling and morning stiffness and problem with relationships and difficulty in dressing and et cetera, et cetera. And on the right-hand side, actually, you see especially how different the patient's perceptions are compared to the perception of rheumatologists, which are shown in blue bar, and red is the dermatologist. So it's interesting how what we think is important from the patient's point of view, and we are of course inflammation doctors, so we want to cut the inflammation and the joint swelling and etc., etc. But from the patient's point of view, there may be completely different things, and it is so important to ask the patient what ails them and what is bothering them the most, and taking that into account when we're treating them. Fatigue, we spoke about the depression and anxiety, and we don't always want to open that Pandora's box, but it is important to ask the patient and making them the center, rather than deciding, oh, I'm going to treat your inflammation the way I want it, but then completely forgetting about that the patient's importance may be something different. So, Chris, can you talk about the key players in the management of psoriatic arthritis? It clearly is a sort of coordinated multidisciplinary approach. And how do you do it at your center?
Well, Atul, like many other centers in the United States now, we've turned to a model in which we have either a clinic where we're working right with a dermatologist, or that we are working together with them in separate facilities with the same patients. In our model, we're in the dermatology office. I have a fellow with me. There's 3 or 4 dermatology residents. We may have a nurse practitioner with us as well. And the basically the resident or the fellow will go in first, or together. They will get a derm and rheumatologic histories, and then we'll all come in and physical exams, and then they'll present to us, and then we'll discuss with the patient, both from the dermatologic and from the rheumatologic perspective, what we think is happening, and then we'll come together with a therapy that will address all of the domains separately. So usually I'll obviously depend on the dermatologist to talk about the skin and the nails, and then we'll talk about the musculoskeletal structures, and then we'll all get together to talk about at the end the other factors: comorbidities, anxiety, depression, financial challenges they might have with medications, other kinds of issues that will come up and frequently do. And I think that this is really critical, because if you don't do this kind of approach, you're like passing ships in the night, where the patient is looking for something here and you're
Yeah,
looking for
exactly.
here, and
Right.
you're not connecting at all.
Right.
You know, you would think that, and we were worried about this when we started doing it, that having so many people in the room at the end would freak patients out. They actually love it because they
Mm,
feel they're getting attention. People are
yeah.
listening to them. We discuss openly in front of them what's this therapy we think is better than that one and why, and then we try and explain. We do explain to them, you know, how the drug's working and why we think you should go this way or not. And sometimes we have minor disagreements in the room in front of them, and we come to some consensus. And they really like that. And so the other
Yeah.
part of this is it requires 2 copays and two payments, because one's
Right.
room and one.
Right.
We've never had a patient complain in 10 years, never
Yeah.
once.
Yeah. I mean, it's pretty complicated, and I mean, there is a great question also about this. We are having actually lots of questions, so I'm going to wrap up very quickly. But about cultural disparity, I mean, in 2020, we have to basically talk about that, and that's something. I mean, we also have a combined clinic, and do you want to? I mean, we mentioned a little bit about the Hispanics and African Americans, but the cultural disparity can also be about the patient's educational, their health educational level, and that's also, I think, is helped when you have got 2 3 4 people there, and that's a great time to educate people, right?
Absolutely. Could
Yeah.
not agree. Could not agree more.
All right, so this has been a terrific, I mean, this has been an amazing discussion, and I want to thank you both. I want to conclude, I want to summarize here. So the advances in the understanding of the pathogenesis of psoriatic arthritis has led to this significant increase in the pharmacologic treatment options. As Chris, you showed earlier, our toolbox has become bigger. IL-23 inhibitors is the newest tool that we have, and guselkumab is the most recent approved treatment, FDA approved, for the treatment of psoriatic arthritis, and the first IL-23 inhibitor. And a very important point is this holistic patient-centered approach to ask the patient what is important for them, not just thinking what is important from our point of view, and addressing all aspects of the disease and provide comprehensive care, and the education is extraordinarily important and essential. So I also want to leave our audience with some of the SMART goals. The SMART goals are these: specific, measurable, attainable, relevant, and timely. goals, and this is accurately diagnosing psoriatic arthritis by utilizing simple and easy to administer screening questionnaires, reduce delay from symptom onset to the rheumatology referral by identifying symptoms that might suggest referral. Now, this really is for the dermatologists, and we educate our dermatologists how we should be reducing the delay from the symptom onset and referral to us if somebody has joint aches and pains, and utilizing the clinical evidence for targeted agents. We have got many of them when we are creating the treatment plans, taking into account the patient's whole well-being, and collaborating with the patient first and with the other clinicians to provide the optimal care. So I'm going to stop there. We have received a number of questions, and thank you all for submitting your comments and questions. And let's see, we have answered some of these. So here is a question. Let me ask this to Chris. I mean, is there any role for biomarkers to choose treatments and make well, it's two-part question. Are there biomarkers for making accurate diagnosis, and are there biomarkers for choosing a treatment?
These are great questions and something we spend a lot of our time working on, to be honest with you, with our we're collaborating laboratories right now trying to figure this out. So there's the biomarkers you can think about are biomarkers that can predict which patients with psoriasis are going to develop arthritis. That's one type of biomarker. Another biomarker that suggests which patients are going to have a more severe course, either with erosions or fusion or axial disease. And then there's biomarkers that can tell you, well, you might want to pick drug A over drug B. We are still not very far along in any of those biomarkers. There was a study that was published out of Japan where they used flow cytometry of cells, peripheral mononuclear cells in patients with PSA to pick and to see which cell types were dominant, whether in terms of cytokines, TNF or IL-23 or IL-17. And they were able to show that by treating patients based on what the flow cytometry showed as to which cell population was dominant, they were able to obtain better outcomes than usual care. So that was a first glimpse that maybe some type of approach that used some cell population subsetting may be effective. And I want to be quick here, there's now abundant technologies we now have available to us through single-cell RNA-seq and other kinds of modalities that are allowing us to segment cell populations in individual patients. So I don't think we're there yet, but we're getting there. And I think within the next 5 years, this will be something we'll actually be able to apply, at least in the trial setting and maybe even in the office.
One thing which we did not cover, and about the sort of, ultrasonography could be a biomarker, right? I mean, patients who have got psoriasis, and if you find on ultrasound that they may actually have some early evidence of inflammation in the enthesial areas, and is that a biomarker in a way for predicting who's going to have developed psoriatic arthritis? And extending this question, do you think there's there's a biomarker to do ultrasound to decide whether they're responding or not responding, or?
So the answer to both questions is yes. We have data that we've presented and ready to submit that actually ultrasound was an excellent biomarker to predict which patients were going to go on to develop psoriatic arthritis. And this is basically on enthesial measures. And also, we've seen work from Leahy Eater and others, European investigators, who have shown that you can use ultrasound to look at treatment response, and that persistent signals would suggest you probably haven't reached where you want to get to in terms of quenching inflammation. So yes.
Yeah. There are a few questions about, there's one question about alcohol use, and there's another question about pain medication. So is there anything in the treatment guidelines about, we did speak about smoking stoppage, that actually is a strong recommendation. Is there anything about alcohol in that?
Philip?
I'm not aware of any specific commentary and so it's just a common sense point to make that if you've got a patient who's, say, on methotrexate and is obese and has fatty liver, it's worthy of asking the question, how much are you drinking, and gently guiding them to drinking less.
Yeah. Smoking is kind of interesting because, smoking definitely has been shown to be a risk factor for development of new bone formation in the spine. And that was one of the reasons I think that was included as a strong recommendation for non-smoking. Um, the we discussed the depression and the anxiety, and patients get significant amount of pain. How do you sort of uh, is there anything about using pain medication, or if somebody's already on that for their pain, how do you wean them off? How do you uh, fibromyalgia? I know, Philip, you really speak about this in your lectures, how important fibromyalgia is. Do you want to give us a quick glimpse? How do you treat their pain, which may not be because of their disease activity, and what do you do with their pain medication?
Well, you've already spoken to one aspect of it, which is we try like crazy to get patients off of narcotics if they're on it, because of the abundant evidence that the chronic use of opioids will lead to hyperalgesia. And then you could just get in worse and worse shape in terms of being able to control pain. So if the patient happens to be on opioids, we will strongly work on getting them off of them, and we will focus on adequate disease management to control inflammation, and then B, if there is a concomitant element of central sensitization or fibromyalgia or whatever you want to call it. The newest term, by the way, is called nociplastic pain for this phenomenon where we see 20 to 30 or even 40% of some of our rheumatic disease patients having some degree of central pain or fibro. We will sometimes now use the non-narcotic approaches, including use of SNRI medications, it would be an example of that, but also using non-pharmacological approaches to treatment, including focusing in on psychological counseling that may be helpful for patients.
Yeah, Philip, I completely agree. I think that one of the important points to underscore, though, is you have to go looking for this centralized pain.
Right.
And there are lots of pathways to it. Obstructive sleep apnea in our heavy patients is extremely prevalent and a cause of disrupted sleep and centralized pain. Depression and anxiety in today's age, social isolation is huge. And the anxiety levels, as we've already discussed, are really high. And also family stressors. So these are all elements that lead to disrupted sleep, centralized pain, and individuals being totally miserable, even though we're giving them very powerful biologics sometimes. So really important part of the care of these patients.
Yeah. There is a fascinating question about immunogenicity of the agents that we use, that we have discussed here. And so one question is, do we know anything about the newer agents, IL-17 inhibitors or IL-23 inhibitor, guselkumab, for example, their immunogenicity? And I'm going to extend the question and ask you, maybe I should start with Philip. I mean, immunogenicity for TNF inhibitors, we are always worried about in rheumatoid arthritis, and that's why we generally use TNF inhibitors with methotrexate. Somehow it is different in psoriatic arthritis. Do you want to comment about the immunogenicity starting with TNF inhibitors and the other biologics?
Yes, so the best data on immunogenicity comes from the TNF experience, and we know that it's useful to use some methotrexate in the background of infliximab and to a certain extent with adalimumab, where we can see slightly greater effects if, for example, in the SPIRIT head-to-head trial in which ixekizumab was compared with adalimumab, we see slightly higher effect in the patients who had some background methotrexate with adalimumab. And what we do in our practice is we use a fairly low dose of methotrexate, 10 milligrams per week, to try to achieve this effect. We're not aiming to use methotrexate to get efficacy. We're trying to reduce immunogenicity. But with the newer agents, it's less clear that there is any impact from the small percentage of immunogenicity that's seen. So there are anti-drug antibodies that can be seen with each of the IL-17 and IL-23 inhibitors, but there's been no evidence that it's impacted the outcomes. And so in general, it appears that we don't need to use background methotrexate At least that's what's coming out of the data from the, for example, the Spirit head-to-head trial.
Yeah, I always find this very fascinating because, and as you rightly said, Philip, the anti-drug antibodies, and again, there are neutralizing antibodies, there are non-neutralizing antibodies. And then several times, despite having these antibodies, the drug effect is not gone down. So really what people should, or we should be measuring are the drug levels rather than the antibody levels. That's the first point. And several times we use actually methotrexate like you are using to increase the longevity or the drug survival so that they get less neutralization of the drug. Very, very good. So we didn't really cover the disease modification, and I know that the guselkumab, the trial that you are on, Discover 2, that was the large study was done to also look at the disease modification. Do you want to speak a little bit about that, Philip?
It was statistically separated from placebo, the structural damage inhibition
Yes.
in the Q4-week dosing arm, but not the Q8-week dosing arm. That arm just barely missed the statistical significance level. It was numerically better than placebo in that regard. The FDA said, you know, in all other regards, these two doses look about almost exactly the same. We're just going to approve the Q8-week dose. So that's why there's not in the label a structural damage inhibition, but we did see that effect in the slightly more frequent dose with that agent. So we have seen this ability to inhibit structural damage progression with many of the other medicines that we use, IL-17s, TNFs, et cetera. One thing I'll comment on is that it can be a difficult thing to assess in PSA trials. Unlike rheumatoid arthritis, patients don't tend to progress at the rate or magnitude that you see in a rheumatoid arthritis trial. And so it's a little bit harder to demonstrate that in clinical trials in PSA, where it's much easier in rheumatoid arthritis, but still a very important issue.
Well, also because you have in PSA, you have two processes going on simultaneously, right? So you have bone resorption, and then you have matrix being added, and it's really hard to sort those out sometimes.
Absolutely, right. You're right, Chris.
There are two fantastic questions, and we only have 5 minutes, actually 3 minutes. So first question I'm going to ask to Chris, and this is impossible to really give a very quick answer, but is there any data in prevention of development of psoriatic arthritis in patients with severe psoriasis?
This is a great question, and one we're trying to answer in many different ways. A couple of ways that Lee Eder out of Toronto and Alexis Ogdi out of University of Pennsylvania have been going into administrative medical databases to see whether or not they can determine if patients with psoriasis who've received biologics for their psoriasis have a lower likelihood of going on to develop psoriatic arthritis. And you can look at these in these databases. The problem that they're facing is that there's a lot of confounders, and it's not always marked when a patient goes on to develop psoriatic arthritis in the database. And so depending on how you model it and how you look at it, you get different answers. So we don't know the answer to that. We do know work from Dennis McGonigal where he looked at patients with psoriasis who did not have arthritis, but actually had abnormal signals on ultrasound in the absence of symptoms. And when they treated them, in this case, it was a drug ustekinumab, they showed that those signals were quenched. So we don't have that evidence yet. We're hoping to do a clinical trial soon to intervene and try and prevent the onset of arthritis in psoriasis patients at risk, but that's coming soon. But we'll have a definitive answer within the next couple of years.
That's wonderful. And I'm going to apologize to, there are 15 unanswered questions, and I'm really, really sorry about that. We are really coming to the end. There is another important question that I'm going to ask Philip, and that will be the last question. And this is, Philip, do you know of any data on combining treatments for psoriatic arthritis?
So I'm sure the question is not directed at combining biologics with methotrexate. It's the more advanced therapies.
Right.
The answer is it's coming out of registries, but not from any clinical trials. So the most definitive data, especially regarding safety, is going to would have to be done with a clinical trial. We've done shown that patients who are getting a combination of a biologic and a Primilast in the Corona registry, we don't have outcome data. We're showing that the patients who are being treated in that way just don't have quite the benefit from the biologic, and so Primilast is being added. And so far, we haven't seen any major safety issue arising from Corona, but you really need a carefully done study to document that. We haven't seen, although there is some combination of JAK inhibitor and biologics in Corona, that one's, to me, a little bit scarier proposition in terms of the potential for infection. So before doing that, I would wait for a more definitive safety trial that would tell us about this. But as Chris and others have commented upon, when we look to the future, I think combining mechanisms is going to be important to break through this barrier that we seem to have of only getting a certain proportion of patients into remission. And so I think that we're going to, like in oncology, we're going to see more of this coming.
So just two comments on this. It's a very important question. The first comment is that there was a trial using a bispecific antibody, ABT-122, against IL-17 and TNF. Now, although it wasn't better than adalimumab alone for the ACR20, it did beat it for the ACR50 and the ACR70, and there were no safety signals. So that's a really important study that people sometimes forget about. I know Philip was involved with that study. The second point is that our GI colleagues are now in the middle of a combination trial for Crohn's disease. And that trial is well underway. We'll have some data regarding that. In fact, I think there's some data coming out of the next GI meeting very shortly in terms of safety and efficacy. So our colleagues in other areas are combining biologics to improve outcomes, and I am certain that we're headed in that direction.
Fantastic. We can keep on talking, but unfortunately, I'll have to wrap up now. This has been a wonderful discussion. So to receive the CME and CE credit for today's program, please complete the post test on your screen and then click on the request credit tab to complete the evaluation and print or download your certificate. Also, as a reminder, if you would like to claim this activity as a CME for MIPS improvement activity, follow the steps described on this slide, which is going to be here only literally for a few seconds. And thank you, Philip and Chris. This has been a fantastic discussion. I would have really loved to discuss more, but all good things have to come to an end. And thank you to our audience for all the amazing and great questions you sent in. We hope that you'll be able to use the strategies that we have shared to treat psoriatic arthritis in your respective clinical settings. And if any of your colleagues missed today's program, it will be archived at cmeoutfitters.com, cmeoutfitters.com, along with other resources that you may find useful. So thank you again for participating, and thank you for providing the best care to our patients. Good night.